sponsors, our investors, our volunteers. There's so many people involved in making this thing happen. So thank you, and thank you for being here. I'd like to introduce Cheryl Koopman from Amgen. I'm sorry, Cheryl. Excuse me.
Oh, that's all right. We just met. We're new friends.
We're friends forever. Amgen has been a real good sponsor and very involved in Wine and Dine for a while now, so thank you very much.
Well, it's Amgen's pleasure to be a part of this event, and it's been fun to collaborate and help out, but most of all, Amgen's very privileged to help oncology patients with innovative therapies for oncology and hematology. So thank you very much for being so gracious to us as a co-sponsor. Thank you very much.
Hello, I'm Jeff Margolis. I'm a practicing medical oncologist. I'm the president of Michigan Health Professionals, and I'm honored to be here for the 8th annual Wine, WDintheD. What's really amazing about this event is about patients, and it's how well the patients have continued to do. It's a testament to you and all the people that are here, how well we're doing with treating myeloma. Sid tells me that we're up 30% in our attendance now. So this is really becoming the myeloma event for Detroit. We've raised a tremendous amount of money for multiple myeloma and for the Myeloma Research Foundation. So what I'd like to do is to have Daniel talk to you a little bit about what the MMR does and what kind of research we're doing, and then we're going to open up the discussion to the panel for patient questions. Daniel?
Well, good evening, everyone, and thanks so much for being here. So, again, through this event, over $300,000 were brought to the Multiple Myeloma Research Foundation to do important research. And we believe that no two patients are the same. So why should they be treated the same way? And we've put a number of initiatives in place to make what we call precision medicine a reality for everyone. So we'll discuss, we have a fantastic panel, we'll talk a lot about this. How do we bring these new exciting immune therapies to the forefront? What do we do with patients who have this precursor condition? Myeloma is one of the only cancer where, if you have breast cancer, you don't wait for breast cancer to metastasize to do something. Well, in myeloma, up until recently, you would let people develop full-blown disease before we do something. Now we have the capabilities to detect it earlier, to figure out who's at greater risk of progression, and maybe because we have these less aggressive and more interesting immune approaches, do something to intervene earlier. If and when we need treatment beyond the standard of care, we are launching a number of what we call master protocols, where you will be receiving exactly the right treatment given your own unique genetics background. So great work, and again, in the past, patients were seen as human subjects. Now you can all be part of the research. You can be active participants in the research. We want to hear from all of you. You are part of the cure, and Brooke, raise your hand, Brooke. Brooke's going to be back there, and we'll, come and see her, and come and join us. And with this, have a great evening. Thanks so much, everyone, and let's start this great panel.
Terrific. What I thought we'd start off the panel is explaining what each one of us do and what we do in treatment of myeloma. And myeloma is truly a disease that requires a team approach. So I'm a practicing medical oncologist, and I'm kind of the captain of the ship. I see people through the entire disease course, and then I rely a lot on my colleagues that are sitting to the right of me to help me treat people with myeloma. I have a radiation oncologist who helps treat patients with myeloma with specific problems we'll talk about. We use research, we use stem cell transplant. So I'll just have each of them say a little bit about what their modality is, what they do, and how they contribute to the treatment of myeloma, and then we'll open this up to questions.
Thanks, Jeff. I'm Larry Keston, Medical Director of MHP Radiation Oncology Institute, radiation oncologist. And so I play a little more minor role probably in the treatment of multiple myeloma, certainly than medical oncologists. But we primarily are involved in treatment of particular locations where there's a problem, for palliative treatment, where there's areas of pain or discomfort or progression on systemic therapy. Cord compression is another situation that can occur where there's spine involvement of multiple myeloma, and radiation treatment is commonly used in that situation. And then we're also involved, I guess, in earlier phases, like such as a solitary plasmacytoma. We would play a much more significant role, which would be sort of the precursor, I guess, or early stage status of multiple myeloma.
So I again am Daniel Clare, the Senior VP of Research at the MMRF. Been doing myeloma research for over 20 years. I'm a PhD. So I'm involved in the earlier phases where we discover new targets, we discover new drugs. We bring them to the clinic. Within the MMRF, we have a clinical network called the MMRC, which has so far around 81 clinical trials. All of the drugs approved in myeloma have come from one way to another to this consortium. Here, Carmanos is part of this consortium, for example. So I'm kind of the more geeky one who does all the great work before these guys actually can help our patients.
First, I want to thank everybody for inviting me here. My name is Joe Uberti. I head the bone marrow transplant program and the malignant heme program at Carmanos Cancer Center. And under that, we have the bone marrow transplant program. We do a number of transplants for multiple myeloma, over 120 transplants a year right now for multiple myeloma. We have all the CAR T-cell therapy that's available on clinical trials, as well as some of the commercially available CAR T-cells. We have oversight over the multiple myeloma program run by Jeff Zonder in our area as part of the MMRF, as we heard. And a lot of the clinical trials, a lot of the investigational trials run under us, including some of the newer therapies that we have for multiple myeloma.
Terrific. Why don't I open up to questions from the audience first? If not, we've got some questions that people have sent up. Please.
I remember Dr. Cole once telling us that 2015 was a revolutionary year in his humorous way of saying it. So I think I named my child something 2015 because of the great advances they made. What can we look for in advances in treating refractory or relapsed myeloma? I mean, not just a dream 5 years out, but what we can solidly look for and count on possibly having something real in the next 2 or 3 years that's significant.
Terrific. So the reason 2015 was brought up as a year, that was the year that we saw a record number of FDA-approved drugs for myeloma, and really has changed the face of treatment for myeloma. And the question is, what's the big breakthrough next? I think most of us are thinking one of the big breakthrough next is something called CAR T-cell therapy. And that, as you said, isn't 5 years. I think I just talked to Dr. Uberti. We're about 3 months away from opening the CAR T-cell trial at Carmanos. So maybe Dr. Uberti can comment a little bit about what CAR T-cell is, how it works, who might be eligible for the trials.
So CAR T-cells, let me just go over the theory and how it's working right now. There's 2 commercially available products for various malignancies for CAR T-cells, acute lymphoblastic leukemia and non-Hodgkin lymphoma. So we're currently treating patients for those 2 diseases. How CAR T-cells work is that we take a patient's cells by an apheresis procedure. Those cells are sent to a manufacturing facility which infects those cells with a virus that can target the tumor cell. Those cells take about 3 weeks to grow. They're sent back to us cryopreserved, and then we give it to the patient. Those cells, they give them like a blood transfusion. Those cells go in, they can identify tumor cells because they have to identify the tumor marker on the cell surface of the tumor cell, and that's what the virus is injected into the cell to do. So it finds that tumor cell, binds to the tumor cell marker, kills the tumor cell, and expands like crazy in the patient, making really an army of your own lymphocytes that can kill off more tumor cells. So the procedure is really unique, and and really the most probably groundbreaking therapy in all of cancer therapy we've had in the last 20, 30 years. We're using cellular therapy with genetic manipulation to kill off the patient's own tumor cells. So it has been approved for the treatment of acute lymphoblastic leukemia in patients under 25 and patients with diffuse large B-cell lymphoma who have relapsed after an autologous transplant. And in those patient populations, it's worked very well. It's not perfect therapy, and it's not perfect therapy because of two reasons. Number one, the complete remission rate with this therapy is 40%, which although it doesn't sound like a big number, is actually a very big number in the patients who we administer these drugs to, because they're multiply relapsed, have been to a number of therapies, and have really failed most therapies. So the fact that we can achieve a 40% CR rate in patients with ALL and non-Hodgkin lymphoma is really an extraordinary advancement for those patients who have this. Is this a cure for those patients? We don't know yet. It does appear that if those patients achieve a CR and maintain it for at least 6 months, the relapse rate drops pretty dramatically. So that's what we know in the two commercially available products for acute lymphoblastic leukemia and for non-Hodgkin lymphoma. So in multiple myeloma, CAR T cells are being developed. They haven't been approved by the Food and Drug Administration. They're all undergoing investigational trials. So the first thing we have to identify is a target antigen that we can target your cells to kill in patients with multiple myeloma. And most of the CAR T cells, but not all of them, are targeting an antigen called a BCMA antigen, which is a B-cell maturation antigen. It's present mostly on myeloma cells, and they can identify a virus that can target that antigen on your myeloma cells. So we would take your cells if you have myeloma, we would send them off to the manufacturing facility that would inject the virus into these cells. The cells would be integrated into your cell's DNA and shipped back to us. Once we get them, to give the cells, actually you have to give a little bit of mild chemotherapy before you give them. Then you introduce the cells into the patient. And the cells do the same thing as we've seen them to do in acute lymphoblastic leukemia and non-Hodgkin lymphoma. So what they do is they target this antigen on your myeloma cells, the BCMA antigen. It expands, it kills the cells, and hopefully will put patients into remission and keep them in remission for long periods of time. Now, the clinical trials that have been published have had mixed results. They've shown very good responses, but some of those responses have not lasted too long. So we'll have to see as we get more and more experience with these cells, how well they do in the long run. Now remember, we use these in multiply relapsed patients with multiple myeloma. So really the next step when we use a therapy like this, assuming it's going to get FDA approval, but we're a little bit far away from that. So we have to go through a number of clinical trials to get FDA approval for this product. How long that will take, I suspect in another year or so it's going to get FDA approval unless something extraordinarily negative happens with these trials. Now, there are different forms of CAR T cells made by different manufacturers with different components of the viral particle that we put into the cells, and they may have different effects and different toxicities after we give these cells. So how you get this, your cells get sent out to the manufacturing facility, they come back to us in 3 weeks. Once we get the cells back, we start the process. You will get about 5 days of very mild chemotherapy, and it's usually fludarabine and cyclophosphamide. The cells will be infused into you. And then there's several toxicities that occur after the cells are infused into you. One of the first toxicities we see is fevers, chills, low blood pressure, which is called cytokine release syndrome. The second toxicity we see is something else called neurotoxicity. And that's people get confused, they sometimes have seizures, they sometimes have aphasia where they can't speak words correctly. So it can be quite an impressive toxicity that occurs after this. In the patients with ALL and non-Hodgkin lymphoma that we treated, it's about equivalent to going through a bone marrow transplant, an autologous bone marrow transplant, when all is said and done. So where are we with these new cells, these CAR T cells for multiple myeloma? They're coming to our clinics very soon. They'll all be investigational trials. The criteria to go on the trials will usually be patients who failed an autologous transplant within a certain amount of time. That's one of the major criteria to go on these trials. So we're getting to the clinical trial portion of this. They'll be coming to us, coming to other centers very soon as we go through this. So we're very excited about this. Now, will it have the same effect as we're seeing in the 2 other diseases we have these cells? We're not exactly sure yet. Some of the data has been pretty spectacular, some of the data hasn't been as spectacular as we like. Is it a difference in the cells we're making, because some of the CAR T cells are different from one center to another? Is it a difference in the patient population we're giving to the cells to? Are there other things involved in maximizing their effectiveness? That'll need some more clinical trial work to figure that out. But they will be soon available to many patients who fail some of the standard therapies for multiple myeloma. Of all the breakthroughs in multiple myeloma, I think this may be the most significant one. We've certainly had a lot of fine new drugs approved for multiple myeloma that have been very effective. And I think what the future is going to be is how do we sequence the different therapies we have for multiple myeloma? Who gets a transplant? Who gets CAR T cell therapy? Who gets this therapy versus that therapy? And a lot of it will depend on what we just heard. Once we have the genetic fingerprint of your disease, we will be able to sort out, I think, a little bit better what therapy will work in different subsets of patients with multiple myeloma. That's further on down the road here, but that's really where we're headed. How do we define what is the best therapy for all these therapies we now have for multiple myeloma? Who gets Darzalex, or who gets Kyprolis, or who gets a bone marrow transplant, or who gets CAR T cell therapy? How do we sequence those various therapies in treating patients with multiple myeloma? Certainly we hope someday we'll have a cure for it. I don't think CAR T cell therapy will be a cure yet. I don't think we've seen enough data to suggest one way or another, but perhaps it will be a cure. But obviously what we want to do is keep the disease under control until we do find a cure. That was a long answer about CAR T cells.
I think one of the things that you see with the CAR T cells, it just means, or just adds to the weapons that we have against myeloma. And now when you add this super weapon to the good weapons that we already have, we may be achieving cures. And it may be CAR Ts by themselves aren't enough, but it may be combinations of CAR Ts with some of these newer treatments, or adding it with monoclonal antibodies or drugs, maintenance treatment. But I do think that we are on the verge of curing myeloma. And it's because of the great kind of research that we've been putting together and drug development that this is finally something I think we honestly can say. And you want to talk a little bit about some of the new trials that you guys are putting together with CAR T?
Well, first of all, so just to add to CAR Ts, you know, I talk to patients almost on a daily basis, and these CAR T trials right now, you know, take some time because, you know, there are some safety issues. Those are very powerful approaches, and you need to go very slowly. And I often see patients being quite discouraged because they could not get on the CAR T. I would just want everyone to realize there are other approaches out there that can give you as much benefit as CAR T. Right now, as Joe mentioned, the truth is it's about only a year before these patients relapse on this current CAR T. So this first generation may not be enough. It may be second generation, third generation before you get these kinds of highly effective CAR T approach like the one we have in childhood leukemia, this old girl at Penn, who's now almost 10 years out of her CAR T infusion. Going back to other approaches that are on the horizon, I was mentioning before, you know, we're all different, we all have different blueprint of the disease, and there may be ways to attack that. There is a drug right now in phase 3 called Venclexa, and it targets a specific population of patients, those patients who have a specific translocation, the translocation 1114. And there we see patients that are even a couple of years out with only Venclexa plus Dex. So the point is there are other agents out there that may be able to specifically target your specific type of myeloma. And from the work we've done, there's probably at least a dozen of these different types of myeloma, each with their own Achilles heel, each with their own liabilities that we could go after. So we're launching this fall what we call a master protocol, kind of a octopus protocol if you want, where patients are being molecularly profiled. We look at the blueprint of your DNA, and depending on what we find, you go on arm A or arm B or arm C or arm D, using these kinds of very targeted approach like this drug called Venclexa, which is one of our arms. We actually just got the IND in research terms, kind of the license to drive a trial. We just got the IND on that study. last Friday. So that trial will be opening sometime this fall. In addition to CAR Ts, as we were mentioning, in these relapsing patients, these patients, who have seen a lot of the agents last for about a year. How about if we bring those CAR T up front, very early in the disease? And again, doing a lot of genomic and molecular work, we've identified some group of patients who are the worst of the worst. We call these high-risk patients. And for those patients, we believe now that we know exactly how to identify them, and we can convince the Food and Drug Administration, the FDA, to say, these patients should probably not even go to the current standard of care. We should do something different for those patients right off the bat. And maybe these are the patients where we can maybe test these CAR T first. And maybe if you give these CAR Ts to these patients at the very beginning, maybe you'll get many, many years out of them instead of the 1 year we get right now in these relapsing patients. So that's I think another exciting trial we're about to start. I'm looking forward to talk to you more about this probably next year.
One of the things at the beginning of the panel, Dr. Keston referred to isolated plasmacytomas, and that's what some people think is a very early form of myeloma that we're actually curing in some patients. So Dr. Keston, can you explain to people what isolated plasmacytoma is and what the role of radiation is for those?
Sure. So isolated plasmacytoma would typically occur in the bone, but could also occur in soft tissues next to the bone, like in muscle. And these are essentially the malignant plasma cells that eventually can spread and cause multiple myeloma. After a lot of extensive staging to make sure that there's no malignant plasma cells anywhere else, to make sure that it's an isolated plasmacytoma, a solitary plasmacytoma in one particular location, then we would typically treat this with radiation therapy. I don't know if some of you are familiar with radiation therapy, but we use X-ray beams to target the tumor and treat only that specific location. Typically, the treatment is given as an outpatient over several weeks. Fortunately, with plasmacytoma and multiple myeloma, it's very sensitive to radiation therapy, as it's sensitive to many drugs, and so therefore we don't usually have to go to what we would consider a higher dose of radiation, so usually it's a very well tolerated treatment.
So can I have a follow-up here, because it's anecdotes at this point, but often we see that myeloma patient receiving radiation seems to have interesting responses, and there is a part of what you're doing in radiation therapy where again there is this idea that by killing the cancer cells you release what you call this antigen, and actually can stimulate the immune system. And I know in solid tumors some groups have tried this approach of radiation to again enhance the immune system. Any thoughts on that front?
Yes, especially with other solid tumors that are not quite so radiosensitive, like say lung tumors. We've used high-dose radiation treatment sometimes which causes a significant sloughing of tumor cells and antigens into the bloodstream. And in that situation, sometimes these systemic immunotherapy drugs, of which there are many now, may be more effective not only in the location where we're doing the radiation treatment, but throughout the body, because it's sensitizing your immune system to those tumor antigens and allowing your immune system to be more to identify those tumor cells in all locations that attack them.
Hi, I'm Dr. Balaraman. I work with Jeffrey Margolis at the Michigan Healthcare Professionals Cancer Centers. I am a medical oncologist, So I take care of multiple myeloma with immunotherapy, antibodies, enzyme inhibitors, rarely chemotherapy today, happily to say.
Dr. Owen, can you talk, I think what people want to know is, when do people have myeloma that needs to be treated, and when do you have myeloma that you just leave alone and watch, or so-called smoldering myeloma?
So myeloma, we know very well now, is a spectrum of disorders. We call them paraproteinemias. There is a spectrum called MGUS, which could be a precursor to myeloma, and most of these patients do not ever need to be treated. They do have a rate of progression to myeloma, which is about 20% over a 20-year span, so about 1% per year. Patients who actually have myeloma, not all of them need to be treated. There is a group of patients who have abnormal proteins in their blood, they have abnormal cells in their bone marrow, but there is no end organ damage, which means these proteins are in no way compromising the patient's health in terms of abnormal kidney function, affecting the bone by eating into the bone and weakening the bone, affecting the calcium, or affecting the blood counts. A significant proportion of these patients can stay asymptomatic and will not have any problems, and they do not need to be treated. We just monitor them. When these patients transform into active myeloma, where they have either kidney dysfunction, high calcium, abnormal blood counts, or bone problems, or in some cases, depending on the rate of protein rise, the number of plasma cell involvement in the bone marrow itself, or a type of protein called free light chains in the blood, we may classify these patients as early active myeloma, and that's when we begin treatment. And today, I'm sorry I'm late, I think they would have already talked about it. Chemotherapies, for most part, relegated to the back burner. We use enzyme inhibitors with far fewer side effects than traditional chemotherapy for initial treatment for multiple myeloma. I hope that answers.
So Dr. Green, for these patients who have technically asymptomatic myeloma, but who are considered to have active myeloma because they have lots of plasma cells in their bone marrow, they have high free light chain, the rationale for treating those patients is they're eventually going to get into trouble. So why wait for them to fracture bones, get their kidneys in trouble, and treat them early? The question I have is, do those patients still need a stem cell transplant, like people who have very active myeloma, or those people that you consider deferring stem cell transplants to a later date?
I think in most of those cases, as soon as you initiate standard therapy for multiple myeloma, I think one of the options is to go to transplant. So even those patients who don't have the traditional criteria of end organ damage with a high myeloma level in their bone marrow, or high capital N or light chain ratios, or light chain ratios that are very skewed, those are indications to treat. And the reason those are indications to treat is that we know over time most of those patients will progress into multiple myeloma. So it is a benefit to try treating those patients early to prevent some of those complications. And we really do recommend transplanting those patients as well as the other patients who do start therapy for multiple myeloma.
One of the things we notice is that when people get further along in their disease, they get more disease burden. That's when you start to see more resistance to the drugs. So one rationale for starting to treat earlier and earlier is to prevent that from happening, to prevent the disease from progressing, and to wipe out those clones that are going to turn into something bad later that will be more difficult to treat. And that's why I think most of us, once we decide you need to get treated, go ahead and treat with everything rather than just partially treating people.
The combinations and the permutations of everything you're talking about is amazing. How does a patient's general health and age tie into everything you're talking about? Somebody that's 50 years old and healthy and strong has got to have a different protocol than somebody that's 80. And there's so many considerations. Can you take a moment to speak to that?
Sure. So we try to look at the overall patient, and we don't use age as a criteria. In the old transplant days, we would have a hard cutoff date, and the date would be 65 and below to get a transplant, and then anyone above that was never a candidate for transplant, and we'd separate it that way. I think now what we look at is what your overall function is, what kind of organ function you have, how well you're functioning in life. Do you need a walker to get around? Are you on dialysis? Do you need oxygen? What your overall local function is, and we call that performance status. And we typically give transplants to people who have good performance status, and then we sit down and we talk to you. and say, here are paths that we can map out. For some people, going through, intensive therapy and a transplant is something that they wouldn't consider. They have a life event, there's a wedding or a graduation or something that's in the way of the timing of the transplant, and those patients will often defer the treatment to later. We also look at molecular changes within the bone marrow. We can predict some people who are very high risk, and if you try to treat them with less aggressive therapy, you don't have, a very good outcome. So everything is very, very individualized. Joe, if you want to talk about your experience with treating older patients with transplant?
So it's exactly what you said, Jeff. It's not so much your chronologic age, it's your biologic age that really guides us in how you should be treated. There are some patients who are 50 years old who are very poor shape, who have difficulty with treatment. On the other hand, there are some patients who are 75 in great shape, who can get through some of the more intense treatments we use. So we look at the biologic age of the patient. Is your heart function good? Is your liver function good? Is your kidney function good? Is your lung function good? And that really helps us make the decision of whether to go to transplant. Well, most of the data has shown in transplant, at least, patients between 70 and 75 do as good as younger patients in transplant. And that's a selected group of population of patients who are pretty healthy between 70 and 75. The oldest patient we've transplanted right now is 80 years of age. So that's how far we've gone in terms of our transplant age. We're not going to transplant every 80-year-old person, but there are some patients who are 80 years old who have the disease that will benefit from a transplant, who can go through the rigors of a transplant. Transplants right now, which is probably the most difficult therapy for myeloma, is not as difficult as I think many patients know. It is a 14-day hospitalization. Some centers do it completely as an outpatient, and most patients get through it fairly well. The chance of dying with a transplant, an autologous transplant for multiple myeloma right now is pretty close to zero. So we've taken patients on dialysis to transplant. You don't need renal function. We've taken patients with some heart problems and lung problems. So we've been able to overcome some of the toxicities of the chemotherapy we use with many of our patients going to transplant. So it's not a picnic to go through a transplant, but people can go through it even at older ages. And the data has supported they probably do just as well as younger patients who go through a transplant.
There's a patient that's here in the audience who wanted to transplant, and then 2 or 3 years later ended up with the flu and in the hospital. And he told me the flu was much worse than the transplant.
Well, the other thing, you want to say anything about this so-called mini transplant? Is that something you guys do? Is that something you want to talk about?
So the mini transplant refers to when you have a donor transplant. So we don't think about that too much in multiple myeloma. Multiple myeloma, we usually use autologous transplants, which is using the patient's own stem cells. When we do a donor transplant, which we don't use too often in multiple myeloma because the other therapy is so good, that's when we do the mini transplant. So we don't do that too much in multiple myeloma. What we do in some of our older patients with multiple myeloma, we decrease the dose of chemotherapy. We decrease it a little bit by 30% over what our more healthy patients get. So that's one thing we do.
Sophia, do you want to comment on how you treat older patients with myeloma?
Again, I think the treatment of myeloma has been revolutionized over the last decade and a half. So when I talk about my older patients, I look at the patient's chronological age, their performance status, what other comorbidities do they have? Do they have diabetes with pre-existing neuropathy? Because what happens is now, because we have so many drugs, we're very effective in treating and getting those patients into remission more often than not. It's the long-term side effects of the treatment that can limit the quality of life. So I talk about, what is their functional status, how is their diabetic neuropathy doing. Today with subcutaneous injection rather than intravenous injections of Velcade, the rate of neuropathy is lower. So managing side effects becomes more important for those patients because it's not just about longevity, it's about quality of life as well. So when you talk about a pill like Revlimid, some patients can have GI toxicities. When I talk to the patient, I talk about, okay, how are your bowel movements? Do you have GI upset? We're using drugs like Colestipol, which is an anti-cholesterol drug for management of diarrhea with Revlimid or lenalidomide. So managing side effects as well as getting them into remission, not just basing treatment on age as a cutoff, is very important. And we do see a lot of older patients whose quality of life is impeccable on treatment. There are a lot of patients who go on treatment-free intervals. We're able to get them into remission. They either are not candidates for transplant or don't want to go through a transplant, but their disease is either dormant or in remission. They don't want to be on maintenance therapy, so we just monitor those patients as well, and they can stay in that state for quite a while.
This is one of the diseases that this is not a sprint, it's a marathon. What we want to do is to make sure that you can maintain and be in this marathon without accumulating a whole lot of side effects and emphasize quality of life. One of the things we found with myeloma is that we have acute induction treatments, consolidation treatments, and then we actually have a maintenance phase of treatment that by putting people on low doses of meds with very small amounts of side effects, that the remissions that we induce get better and better and better. And that now the standard treatment after a transplant is actually to give people maintenance treatment with a drug like Revlimid that actually prolongs survival and keeps the remissions longer. Other questions?
What are the usual symptoms that will happen?
We'll talk about some of the symptoms you see with myeloma symptomatic, Dr. Keston, and symptoms.
Sure. Pain in a particular location would obviously be a common a symptom. There are anemia is a common presentation, so fatigue, or any, being pale, findings consistent with anemia. If there's back pain, then you could have neurological issues or, tingling, numbness in a particular location. Those would be some common, I guess, physical.
So one of the things that we do to define myeloma and symptoms, we have something called CRAB criteria. Dr. Bauer, maybe you can go over those.
So CRAB criteria, C refers to hypercalcemia, R is renal or kidney dysfunction, A refers to anemia, and B refers to bony lesions or bony disease. There are quite a few patients, believe it or not, we pick them when they're completely asymptomatic. A lot of us are getting blood work as part of our annual physical. If your doctor finds out anemia, he sends you to a hematologist for workup, and as part of the workup, we get a myeloma panel, and that's how we pick up a lot of patients. We do CAT scans and x-rays more frequently than we ever did. We can pick up bony lesions on CAT scans. So a lot of our patients are actually asymptomatic when we diagnose them with multiple myeloma.
Question?
For a patient that has an isolated oropharyngeal plasmacytoma, what is the workup and follow-up?
Well, workup would first be an extensive staging study to make sure it's isolated. So that would involve CT scans, MRI, probably PET scan, a bone marrow biopsy. There are several other blood tests that the medical oncologists are usually involved with, serum protein electrophoresis, some other laboratory tests that you would need. If after all those studies are done, it's found to be an isolated plasmacytoma in that particular location, then the primary treatment is radiation therapy to that location, typically for a course of about 5 weeks. There's some controversy regarding surgical resection in these situations. You can certainly operate. When you're dealing with lymphomas or multiple myeloma type tumors, it is very difficult to determine margin status, and so oftentimes you have to add postoperative radiation treatment, even in the setting of surgery. In a situation where there is an oropharyngeal cancer, that can be a difficult surgery location, so I think one would usually opt toward radiation treatment.
Other questions?
Yeah, my question is with the Nobel Peace Prize announcement in medicine, where the therapy doesn't attack the cells, but focuses on the immune system. Is that trickling down into myeloma research?
So checkpoint inhibitors are what you're referring to, and you'll now see television commercials for the multiple checkpoint inhibitors, Keytruda, Opdivo. Those drugs have permeated through most places in cancer, and we've used it in lung cancer, head and neck cancer, Hodgkin's lymphoma, bladder cancer, and sure enough, they've been tried in myeloma. And unfortunately, the preliminary results for myeloma have been quite disappointing, and some of the studies had to be prematurely stopped. It may be that we're not sequencing and using these drugs correctly, And one of the ways it was alluded to earlier on is it may be what you should do is radiate one of the sites, increase the amount of tumor antigen, and then try some of these drugs. We know in solid tumors that the more antigen the tumors express, the messier the tumors are, the more likely these checkpoint inhibitors are actually going to work. So I think for checkpoint inhibitors right now, outside of a clinical trial, we don't use them. I don't think we've given up on them for myeloma. I think we're re-looking at how we pair them and what we do with them. Dan, you want to talk about where we're at with trials with that?
Sure. A few things. First of all, there's when you talk about these kind of agents, there's an army of them. So those that have been the most advanced in the clinic are around targets called PD-1 and PD-L1. And those are the ones which in myeloma so far have proven disappointing. I would say, however, these checkpoints in solid tumors have been working best in cancers where you have a lot of mutation, a lot of damage, like in lung cancer, in melanoma. And there is a subset of myeloma that has a lot of these mutations and damage, and it's being tested in there. On top of that, maybe for myeloma, it's not the PD-1 or PD-L1, there are other soldiers in this army, agents like LAG-3, TIGIT, and others. And those are being studied right now in trials that we're starting. So we'll see. We haven't given up for sure.
Other questions? So one of the things I've been asked as a question to bring up is cost of therapy. And one of the things that's happened with the treatment of myeloma, we've made tremendous progress in the treatment of myeloma, but it's come at a huge financial cost. Just to give you an idea, Dr. Yuri, what's the drug cost just for the CAR T cells?
So the CAR T cell infusion now, just the infusion of the cells, is either $375,000 or $475,000. And this is a real problem. I mean, there's so many ways we can't even start. Certainly, one of the biggest problems we have is Medicare reimbursement. So Medicare has decided they're not going to reimburse us for these cells. So if you think about the patient with multiple myeloma, the average age is 67. So if CAR T cells come to be used in multiple myeloma, most of the patients who may be eligible for it may be on Medicare. Medicare will pay us, think about the cost of the drug alone, it's probably going to be around, let's say, $350,000. The supportive care is another $200,000. We're already even, $550,000 per patient for one treatment. Medicare is going to reimburse us on that for about $160,000. So there's no way any institution can do this financially without some tremendous losses. So Medicare has to change the reimbursement for the CAR T cells, or it won't be readily available to patients with Medicare. And we're fighting that now tooth and nail to try to improve the reimbursement. But the cost of the drug alone is more than Medicare will reimburse us. So that is really a major problem in using this very effective therapy for multiple patients. And again, if it gets approved in multiple myeloma, over half the patients with multiple myeloma will have Medicare. So we have to find a way to pay for these equitably, to give this to our patients, to not put every hospital at risk that treats these patients with tremendous losses to patients. It's a problem with all drugs. I mean, if you think about our patients on Revlimid therapy post-transplant, some of them are on it for 5 years. The cost of that is almost $750,000. I mean, that's a lot of cost, to society, to everyone, to the patient, to everybody taking care of that patient. So the cost of every drug is just skyrocketing beyond control. And it really makes it tough for our patients to go through this.
One of the things that's unique in Michigan is that we're not an oral parity state. And so that means that you may get drugs that are paid for intravenously and your insurance will cover it. But it may be you get a drug like Revlimid that's an oral drug or Pomalyst that's an oral drug, it's not covered. And the drug's $12,000, $14,000 a month, and people are having to write big checks every month just to get their drug. If they were coming into the office and getting the drug infused, the drug would actually be covered. So one of the things that we need to do as patient advocates and patients is really start to lobby and say, for these drugs, we need much better coverage, because it's great to have great drugs, but you can't treat people with them because of the cost. They don't do any good.
I would urge everyone to write their local people in the state senate, state house of representatives to support oral parity. This will allow better coverage for all these drugs that are becoming so expensive for all our patients. Michigan is only one of 12 states or 13 states in the country that doesn't have oral parity. So we as consumers pay more for our oral drugs, the chemotherapy drugs that have become more expensive than almost all the other states in the country because we haven't passed an oral parity bill. And it's something we need to pressure our representatives to do.
Some question over here?
How do the pharmaceutical companies fit into this scenario?
We've got some in the audience, if anyone wants to answer. They have a large cost for doing research, and they're trying to get that back and to get a profit. And then they fall into this system that's got a broken reimbursement, system. One of the things that is broken about the system is that if you were to have commercial insurance, almost every one of the drug companies would give you copay assistance, and they would pick up whatever your copay is. Your insurance would pay for 80%, 20%, the drug companies would actually pay for. When you have Medicare, the government has decided that's an inurement and a bribe to take these drugs because you really want to take them, and they're prevented from actually giving you these copay assistance. So commercial insurance patients get copay assistance. People who are extraordinarily poor and can't afford it, don't have insurance, the drug company really comes to the rescue. But unfortunately, once you turn 65 and you go on Medicare, then people are actually not able to help you as much, and people are falling through the cracks.
Velvamet's a drug that's been around for quite some time, and obviously is a derivative of thalidomide. And why is it that available in a generic form?
I think Revlimid eventually will go into a generic form, but one of the problems with Revlimid is in a generic form is that it's also a drug that's part of a REMS program. And that REMS program is a monitoring program to look for toxicity outside of the patients that are taking it. That REMS program has a separate patent. So even when the drug goes off patent and generic comes up, the company that comes in is going to have to pick up and kind of put together this REMS network. So I don't see generic Revlimid, coming and making an impact real soon until we can get through some of the legal work it has to do. Other questions? Well, I think the evening is starting to get closer to dinner time. The dinner bell should ring soon. I know that Sid has done a lot of work. We've got a lot of great wines to taste, a lot of great food to sample. What we're going to do is we're going to make ourselves available to come up here to the committee, and you're welcome to take questions. One of the things that we're doing in the future is we're putting together a practice with the doctor. And so in each of the areas around the city, the panelists agreed to sit down and meet with individual patients, 6 or 7 patients in a small group, talk about what goes on with myeloma, what questions you might not want to ask in a big group here, what kind of problems that you're having, what kind of side effects you're having. And we'll have these groups available throughout the city this year. So, Sid?
We've had a few already, but we're planning a lot more in the coming year. So just email us and we'll be on the list.
Everyone hear that?
You can find it on the Cure Multiple Myeloma, I believe it's .org, which is the not-for-profit that Sid has started, and all the funds from that come to the MMRF, but you can find out more about his breakfast at his site.
Terrific. Thanks, everybody.